Hi, everybody, and welcome to the Celiac Disease Program at Children's National Hospital. I'm Vanessa Weisberg, the Executive Director of our program here, and I'm very excited to introduce today's webcast. We are going to be talking about autoimmune diseases and whether or not they actually travel in groups. We know lots of our patients and their families have multiple conditions, so we are going to dive into that topic today to learn more. We have our amazing community education specialist, Kate Raber, here today, who is going to do this presentation. It's a topic she's really passionate about, and I'm very excited to have her doing this lecture for you. And we also have Dr. Benny Kersner, our medical director of the Celiac Disease Program, to chime in and talk about all of the medical stuff. So without further ado, I will hand it over to Kate and Dr. Kersner.
Thank you so much, Vanessa. And once again, welcome to this month's podcast. So today, like Vanessa mentioned, we're going to be talking about autoimmune diseases and whether or not they actually travel in groups. It is often said that when you have one autoimmune disease, that many or some go with it. And so we're going to investigate some of the more common diseases that we tend to associate with celiac disease. So on the agenda for today, we're going to look at the idea of autoimmune diseases just in general and the idea of them traveling in groups. And then we'll move on to a few of the autoimmune diseases that are commonly associated with celiac disease. So you'll see those listed there. And then finally, we'll wrap it up and give you some take-home messages about how to use this information. So do autoimmune diseases really travel in groups? Well, the answer is yes, for the most part. We're not really sure why, but we do have an idea. We do know that autoimmune diseases are a mixture of several different factors, a lot of those being genetic factors and some of those being environment factors. About 3% of the population of the United States has an autoimmune disease, which is actually quite a hefty number. And 25% of individuals with one autoimmune disease also have a tendency to develop another. So we do see a lot of cross-diagnoses. There are no cures to autoimmune diseases, however. There is only treatment to take care of some of the symptoms. Now, one of the big things is recently is that research into cures for celiac disease are coming along really nicely. And those are really interesting because celiac disease is the only autoimmune disease that we know of that has an on and off switch. So this means that we've identified a trigger that when we take it away, we're able to erase evidence of the disease. That means we're not able to erase the disease itself, but we can at least have normal blood work and normal biopsy. So that means it's thought, however, that if we do find a cure for celiac disease, that could open up a whole new world of research for other autoimmune diseases. Now, at the bottom of the slide here, we have a diagram of our chromosomes. We have 23 pairs of our chromosomes, but we're only going to be focusing on chromosome number 6 today. So that's the one in the red box there. So this is the number 6 chromosome here. I'm going to have Dr. Kersner explain a little bit about chromosomes and what this specific chromosome does.
Well, chromosomes, as you know, determine who you are, what your chemistry is. It also determines what your immune responses are. And the area of the chromosome setup where immune responses reside is this HLA region shown over here. It's the human lymphocyte antigen region. And it seems as though defects in that region may not run alone, but occasionally will be adjacent to another defect. And hence you might have both diabetes and celiac disease, similarly located in the chromosome setup. And one could envisage that a mutant tendency in the one might affect more than one region. And possibly that's why we're seeing these linkages.
So let's take a look at a couple of the autoimmune diseases that we're going to be discussing today and where their genetic markers are, or at least some of their genetic markers are in relation to celiac disease. So first we have celiac disease here, located, as we know, DQ2 and DQ8 are the genes most associated with celiac disease. So the next disease, Sjögren syndrome, there are markers that we know of both on DQ and DR in the class 2 of the HLA region. Autoimmune hepatitis we find in DR. Addison's disease we also find in DR. Type 1 diabetes in DQ, just like celiac disease. Multiple sclerosis in DR, and then Hashimoto's disease also in DR. So we can already see here that several of these autoimmune diseases are related not just through the same chromosome, but in the same arm of the chromosome, as well as in the same region and the same class, and even in the same region of these classes. And so it's really not that far-fetched, like Dr. Kirshner said, to say that many of these autoimmune diseases are related to each other, and a defect in one part of this specific part of the chromosome, it would not be far-fetched to say that that would lead to another defect. So the first autoimmune disease we're going to look at is type 1 diabetes. This autoimmune disease results in the body attacking the cells of the pancreas that make insulin. This can cause high levels of glucose in the blood, which can become very dangerous. Now, aside from celiac disease, risk factors can include things like family history, genetics, your geography, and your age. Type 1 diabetes is typically diagnosed during childhood or early adolescence. So some things that doctors look out for are excessive thirst, which then goes hand in hand with frequent urination, unexplained weight loss, fatigue, and excessive hunger. If you do not treat type 1 diabetes, there are several serious complications. They include things like kidney disease, stroke, heart disease, nerve disease, eye disease, and various skin infections. So Dr. Kirshner, will you tell us a little bit more about type 1 diabetes and just a basic idea of what the tests for it look like?
Sure. Well, type 1 diabetes means that you have lost the ability to produce insulin. Insulin does two remarkable things. It drives glucose into the liver, where it is converted to glycogen, like the starch of plants. This is your storage sugar. And it also influences your absorption of sugar from the intestine. So it is a central controller of your blood sugar. If the blood sugar is allowed to rise, it will spill out in your urine. If it spills out in your urine, it drags water with it by osmotic tension. You become dehydrated. Because you're dehydrated, you're acidotic. But over more extended periods of time, the defect in sugar metabolism and fat metabolism that accompanies it leads to vessel disease. Narrow vessels leads to ischemia in those organs, hence horrible effects on so many parts of the body. What else can I tell you, Kay?
So what would a diagnostic test for type 1 diabetes look like the fasting blood glucose test?
Yeah, the most important thing, certainly for a celiac patient, is to just be aware that if you're waking up too frequently at night to urinate, if there's increased urine output, you should have your sugar in the urine tested. If it's suspicious, you want to go ahead and get blood tests done to see what the sugar is. Now, there are crises. Some of these young children, unfortunately, present in dehydration, in a dehydrated and ketotic state. They will wind up in the emergency room, and no doubt they will do these tests there. Now, one of the issues that comes up in the celiac population, and will come up again and again through this discussion, is, so we have celiac disease, what should we do to make sure you don't have diabetes? Let me be clear on this, not a whole lot. We are not advocating that you go and get the very specialized tests for diabetes, which are islet cell antibodies, but that you are aware, of the condition, that you check your urine. And actually, although it's surprising that amongst diabetics, there's a very high incidence of celiac disease, the converse is far less true. So amongst celiac patients, we don't have that high an incidence of diabetes. So we don't feel compelled to do definitive tests for diabetes on a routine basis, other than to make people very aware of the association. However, if you happen to be diagnosed with type 1 diabetes, then you absolutely need to be screened for celiac disease. even if you're asymptomatic, because we fear that with celiac disease, you could have effects on bone that would be hidden, and we need to get there early, particularly in childhood, and sort this thing out.
Yeah, absolutely. So with type 1 diabetes, treatment includes a number of things, the biggest one being taking insulin. That can be done via injection or an insulin pump. Carbohydrate counting is really important, as well as blood sugar monitoring, as well as eating a healthy diet, exercising regularly, and maintaining a healthy weight. When it comes to your medical team, the endocrinology, that is the specialty for type 1 diabetes. But of course, you should also keep a couple of other doctors in the loop as well, like your primary care physician. A dietitian would be nice to have, especially at the beginning of the right after diagnosis. And then an eye doctor, whether that be an optometrist or an ophthalmologist, as there can be different eye conditions that come along with type 1 diabetes. And then finally, a mental health professional, which is really advisable in the diagnosis of any autoimmune disease or any chronic illness. Now, a big question that we can hear sometimes is there any relation of type 1 diabetes to type 2 diabetes? And the answer to that is no. Type 2 diabetes is not an autoimmune disease. This is a result of the body not properly responding to insulin. So the body still does produce insulin, but in type 2 diabetes, the body is just resistant to it. So there's a really great diagram here on the right-hand side of the screen, and you can see the difference between what a normal situation would be, what type 1 diabetes looks like, and type 2 diabetes. So you can see that the pancreas is depicted by the factory, and insulin is depicted by the key, and that the cells are depicted by the house in the photo. The job of insulin is to act as a key to let the glucose into the cell, which then allows the cell to convert that glucose into energy. Now, in type 1 diabetes, the body is attacking the pancreas, or the factory in this situation, which means that insulin is not there to act as the key to allow glucose into the cells. Glucose then can circulate freely throughout the blood in the body, and we therefore can't use it as energy. However, in the case of type 2 diabetes, the pancreas is still producing insulin into the blood, but the insulin is kind of like a damaged key, one that's been worn down a little bit, so it doesn't really fit the lock. So the lock then won't accept it to gain entry into the house or to the cell. So this is what we call insulin resistance. Now, one thing to keep in mind about type 2 diabetes, it cannot turn into type 1 diabetes, but type 2 diabetes can occur in individuals with type 1 if a poor diet is something that's being followed. One thing to look out for, not just necessarily from a diabetes standpoint, but just from a basic dietetic standpoint, is that a lot of gluten-free foods are very highly refined. A lot of them lack vital nutrients that their gluten-containing counterparts contain, and that's especially true in the case of fiber and protein. And because gluten is what gives things like baked goods its texture, that's why you'll find a lot of really crumbly baked goods out there. And so to make up for this loss of texture, a lot of companies will often put more fat or sugar into gluten-free products to make them taste better. So we have an example of that here on this slide. To the right, we see a gluten-containing pizza crust, and to the left, we see an Udi's gluten-free pizza crust. If we look at the nutrition facts on both of these, we see that the serving size is the same amount for each product, 57 grams. But if we start to look a little bit more closely at the label, we look at calories, we can see there are 20 fewer calories and 15 fewer calories from fat in the regular pizza crust than in the gluten-free pizza crust. This can also be seen in the total fat, which for gluten-free has 1.5 grams more fat. We can also see that carbohydrates and sugars are both higher in the gluten-free crust. And then finally, you can see that there's less protein in the gluten-free crust than in the gluten-containing crust. So this gives you an idea of the disparity between gluten-free and gluten-containing, and how sometimes these processed gluten-free foods can actually be worse for you from a nutrition perspective than a regular gluten-containing product. That just means finding alternative things, especially whole grains, and trying to eat as few processed foods as possible. So the next autoimmune disease we'll be talking about is Hashimoto's disease. This is an autoimmune disease that results in the body attacking the thyroid gland. So it results in hypothyroidism, which means that your thyroid cannot produce enough thyroid hormones. Aside from celiac disease, some of the risk factors include family history, excessive radiation exposure, genetics, age, as most Hashimoto's is found in people of middle age, and sex, as women are about 8 times more likely to have Hashimoto's than men. Some of the common symptoms we see in Hashimoto's are things like fatigue, weight gain, hair loss, muscle and joint pain, dry skin, and also a sensitivity to cold. A lot of people also find that it's just more difficult to lose weight, just regardless of what they do. If we don't treat Hashimoto's, there can be complications like goiters, heart disease, depression, myxedemia, which is a bit like edema, but it's more swelling of the skin, and birth defects in children born to women with untreated Hashimoto's. So I will now turn it over to Dr. Kersner to talk a little bit more about Hashimoto's disease, kind of the diagnosis and the overlap with celiac disease.
Right. This is really interesting because whereas with type 1 diabetes, the risk in the celiac patient is there but relatively low. With hypothyroidism, the risk to the celiac patient is considerably higher. And therefore, as a routine, every celiac patient should have thyroid screens done, we recommend annually. And the thyroid screen is firstly to see if there's enough thyroid hormone circulating, which is called the free T4, and whether the stimulating hormone, the hormone that's inducing the production of thyroid, is relatively high. Because if the body detects that the thyroid gland is not putting out enough thyroid hormone, it's going to compensate by instructing it at a higher level, and your TSH goes up. So very simply, once a year, we would love every celiac patient to get a TSH and a T4 done. If the TSH starts going up, that's a warning, and you might then need to go on and see your endocrinologist and get more definitive testing done. I think for practical purposes, that's what the celiac patient needs to bear in mind. Many of the symptoms, as Kate has mentioned, are, vague. Things like being more tired, cold sensitivity. They don't necessarily imply hypothyroidism, but they certainly should raise suspicion.
So the good news about Hashimoto's and hypothyroidism is that it's really quite a simple treatment. It just involves supplementing your body with a synthetic hormone that's exactly identical to the one that's produced by the body. So that would be levothyroxine, which is commonly known as Synthroid or Levoxyl. And then in some cases, which is less common, but in some cases doctors might also prescribe liothyronine, which is commonly known as Cytomel. Now, as Dr. Kersner indicated, endocrinology, again, like type 1 diabetes rather, is a specialty of endocrinologists. But of course, like any other autoimmune disease or any other medical history, your primary care physician should be involved in treatment and monitoring. Now, there are other thyroid disorders other than Hashimoto's disease. We sometimes see them with celiac disease, but of course, it can sometimes be a little bit more common to see Hashimoto's. Another autoimmune disease that we see is Graves' disease. This is the opposite of hypothyroidism. It causes hyperthyroidism. So hyper means too much. In Graves' disease, your thyroid creates too much thyroid hormone. One of the genes associated with Graves' disease is HLA-DR3, which is in the same region as Hashimoto's, as well as many of the other autoimmune diseases we're talking about. But Graves' is much, much less common than Hashimoto's. But still, out of all hyperthyroidism cases, Graves' is the most common that we see. There is also There are also non-autoimmune causes of hyper and hypothyroidism. We do see that in the case of thyroiditis, for example, which is just a general term for the inflammation of the thyroid gland. Outside of autoimmune disease, it can be caused by several things, and sometimes it's just as simple as an infection. Something like polycystic ovarian syndrome as well has also been known to be linked to thyroid disorders. Now, finally, one of the more noticeable symptoms that I mentioned on the previous slide of thyroid disorders are goiters. So you can see an example of what a goiter would look like. This is quite a large goiter on this woman's neck here on the bottom right of the slide. They're typically not painful, but they do indicate an abnormal enlargement of the thyroid gland and can sometimes either cause a cough or difficulty swallowing and breathing. So if there is some sort of growth or protrusion coming from the neck, that would also be an indication that you should go see your doctor for some sort of thyroid testing. Now, moving right along, we have Sjögren syndrome next. This is an autoimmune disease that results in the body attacking moisture-producing glands. Now, aside from celiac disease, there are risk factors that include sex. Women make up actually about 90% of the population with Sjögren syndrome. People with a rheumatic disease like lupus or rheumatoid arthritis tend to have a higher susceptibility to Sjögren's, as well as just genetics. Symptoms can also be quite vague. Things like dry eyes, dry mouth, fatigue, joint pain, skin rashes, vaginal dryness, and a persistent dry cough. Now, if left untreated, some of the complications and symptoms can include things like dental cavities. Your saliva is very important in washing away bacteria. So if we have a very dry mouth, we don't really have that built-in protection against the bacteria that cause cavities. Yeast infections, vision problems, and various complications within organs for more serious cases like lungs, kidneys, or the liver. So once again, I'm going to turn it over to Dr. Kersner to talk a little bit about about Sjögren syndrome, diagnosing it and its relation to celiac.
You know, there is a higher incidence of Sjögren syndrome in celiac disease, but not that high. It's similar to the relationship we see with diabetes, but even less so. And you know, basically the clinician looks out for features of the illness, and it's easy to bear that in mind because any surface that produces secretions from your mouth to your eyelids, etc., that's dry, brings to mind this condition, and you would want to visit your rheumatologist and get more definitive testing done.
Well, oftentimes, if I'm not mistaken, this will often be caught initially through the anti-nuclear antibody test, the ANA, which will be outdated.
Now, you know, a general screen for immune conditions, autoimmune condition, is the ANA. It's a non-specific test that we apply whenever you think of an autoimmune condition. In fact, if you step back and think of the approach to autoimmune conditions, maybe the simplest way to think of it is to say all organs are subject to a possible autoimmune condition where the body's acting against an element in that organ. Mm-hmm. So we perpetually screen for liver problems, kidney problems, and inflammatory reactions at every visit annually. Mm-hmm. If we find a particular organ's involved, then we're going to ask, is this an autoimmune phenomenon? If it is, we're going to do general testing. ANA would be high up in that list. And there are other non-specific signs of inflammation like your sedimentation rate and your CRP. Once those screens are affected, you ask yourself, what is the pattern of the disease? And that leads you to more definitive testing. The definitive testing is very complex. The variety of anti-organ antibodies is endless and growing. And that's why we need a rheumatologist at that stage to sort it out. And that might still be complemented by biopsies. So if you've got joints involved, you're going to go one way. If you've got skin involved, you're going to go another way. If you've got liver involved, you're going to go another way. If you've got kidney involved, you're going to go another way. If you've got a pattern of disease, so say it's skin and kidney, you might think of things like lupus, where they are gathered together. But in principle, you're going from symptoms to organs to generalized testing to specific antibodies.
Great. So like Dr. Kirsner indicated, really for Sjögren syndrome, the treatment and who you see is dependent upon what symptoms you have. So if you have dry eyes or dry mouth, that's something as simple as eye drops. Some people like to take fish oil for that. There are dry mouth toothpaste sprays and gels on the market. Some people like them, some people don't. There are also a couple of medications, pilocarpine being a very common one that assists with saliva production. And in some cases, especially those with joint pain, hydroxychloroquine or the brand name Plaquenil can be prescribed to assist with the joint pain. And once again, a rheumatologist should be the primary point for diagnosis, and then, of course, looping in your primary care physician. Now, finally, this is, or next up rather, is one a lot of people are familiar with, multiple sclerosis or MS. This is an autoimmune disease resulting in the body attacking its own myelin, which results in nerve damage. So myelin is a protective sheath that covers the nerves and protects them. Now, aside from celiac disease, there are several different risk factors. Some of them include sex. Women are 2 to 3 times more likely to have MS than men. A family history, genetics, race. The highest risk of people who have multiple sclerosis have a European descent. And finally, smoking. Some of the symptoms include things like a vision loss, pain, fatigue, impaired coordination, tingling, numbness, and spasms or tremors. So these are a bit more noticeable symptoms, I would say, than some of the other things that we've seen so far. Now, if left untreated or unsupervised, complications include things like paralysis, a loss of bladder and bowel control, depression, difficulty speaking, swallowing, and a difficulty in speaking. So next up, Dr. Kirsner here will talk a little bit more about multiple sclerosis and whether or not that's something that people with celiac should be concerned about.
I think this is something that affects the older population. I've never seen a child with this condition. It requires a neurologist to do a lumbar puncture, and we do an MRI, the sort of tests that allow us to look into the brain substance and the bathing fluid around it. And again, you will couple that with indications of inflammation and treat with immune suppressants. Frankly, I have little experience with this condition as a pediatrician, happily, but it's very serious, and it is one that we worry about in long-standing undiagnosed celiac disease. We like to believe that diagnosed and treated, this risk is remarkably decreased. And certainly within the context of our own multidisciplinary clinic, we've not seen a case.
That's really great to know, because this really can be a terrible disease. There is no cure for it. Treatment can be tough. It includes, there are several different autoimmune immunosuppressant drugs that people will take. There's a list of them there on the screen. Things like corticosteroids are also taken, which can also be quite hard on the body. But also physical therapy is a very large part of helping to manage multiple sclerosis. So in addition to your neurologist and a primary care physician, it would often be a good idea to see a physical or occupational therapist to keep up some dexterity, as well as a mental health professional, especially in the case of multiple sclerosis. I think that's a very important part of the treatment team. Now, Addison's disease, this will be our second to last disease that we're going to look at. This autoimmune disease is a result, or rather results in the body attacking part of the adrenal gland. So the adrenal glands sit on top of the kidneys, kind of in our mid-back area. Now, this disease results in our body not producing enough cortisol and aldosterone, which are both very important hormones, which cortisol helps to regulate stress, and aldosterone is a hormone that helps to regulate the body's blood pressure. Now, aside from celiac disease, risk factors include genetics, other autoimmune diseases, recurrent fungal infections, and actually certain bacterial infections like tuberculosis. Thankfully, though, tuberculosis is quite rare in westernized countries. Now, symptoms like the thyroid diseases can sometimes be quite vague. Things like fatigue, appetite loss, hyperpigmentation in the skin, low blood pressure, cravings for salt, nausea, diarrhea, and vomiting. If left untreated, complications can include acute adrenal failure and acute Addisonian crisis, which really just involves the body's inability to produce cortisol. So next up is Dr. Kersner to talk a little bit more.
Well, I think Addison's disease, many might know, this is an illness that afflicted President Kennedy. And it's subtle. One of the hallmarks is this hyperpigmentation, taking on a pigmented skin, coupled with this horrible lethargy and a predisposition to infection, and hypertension. The production of cortisone is critical to the body's management of stress, as you mentioned, and homeostasis in general. Again, we don't see this in childhood very often. I can't remember seeing a child with celiac disease who has Addison's. We worry about it, and we occasionally see Addison's. I just haven't seen them linked personally, which I take to mean it's not that common. But certainly for adults and for long-standing celiac disease, we want to bear this in mind. And the testing done really is blood testing. You're basically looking to see what the adrenal gland is producing. And if you detect the defect, you've got a means to compensate, because cortisol is readily available to be given to compensate. I think for practical purposes, that's as far as we should go, right?
Yeah. So treatment is very similar to hypo and hyperthyroid, or really hypothyroidism, and just supplementing to replace what the body can't produce. So that would either involve taking cortisol, aldosterone, or both. And there are synthetic medications that are identical to the body's hormones that are easily accessible. Once again, the endocrinology would be the department to see for this disease, as well as a primary care physician. Now, finally, we are going to look at autoimmune hepatitis. I think a lot of people hear hepatitis and don't really think of it being an autoimmune disease. They think of it more as something that's contracted. But there is an autoimmune component to some types of hepatitis. In this case, it would be the body attacking its own liver cells, which would then result in different complications, primarily being scarring. So aside from celiac disease, other risk factors would include things like genetics, other autoimmune diseases. We see this more in women than in men, and then a history of certain infections, the biggest ones being measles, herpes, Epstein-Barr, and then of course hepatitis A, B, or C, which is something people are a bit more familiar with. Symptoms include fatigue and jaundice, which is very typical of disorders with the liver, an enlarged liver, which is typically picked up during an annual physical when doctors feel for the size of the liver, abdominal pain, a loss of appetite, diarrhea, and nausea. If this is left untreated, complications can include things like cirrhosis, which is scarring of the liver, enlarged esophageal veins, a fluid retention in the abdomen, liver failure, and liver cancer. And so once again, I will leave it to Dr. Kersner.
Actually, celiac hepatitis is not that rare. And quite frequently, the diagnosis of celiac disease is prompted because the general pediatrician or the primary care doctor doing a routine metabolic screen, which we do frequently, will find elevation of two of the enzymes called AST and ALT, which are generally confined to the inside of the liver cell. And when the liver cell surface is inflamed, it leaks these into the bloodstream. So you can readily detect it. And we look for this every year. We screen for it routinely. At the outset of celiac disease, we very frequently find low-grade elevations of these. And that form of celiac hepatitis settles very well in response to the gluten-free diet in the vast majority of cases. There's a subset of cases where it goes beyond this, and we have the presence of autoantibodies against the liver, and they go by interesting names like LKMN antibodies and actin antibodies or smooth muscle antibodies, even though it's liver we're talking about. And when we find those, we know there's an immune component which is more threatening to the liver, as it's likely to result from the inflammation. It will lead to scarring. Distortion by scarring leads to a perversion of the flow of blood within the liver, which leads to ischemia in the liver, which leads to more scarring, which is what cirrhosis is, and that can be fatal. So it can also be prevented with appropriate therapy. And if we find these enzymes rising, we will investigate further for the ultimate cause, and if it's immune hepatitis, we have specific treatment we can use. Having spoken about it, and this, as a pediatrician, I have to look at it this way. In childhood, this is a condition we do see. We don't see it very commonly, but it certainly is amongst the autoimmune conditions that we are vigilant for.
Right, and I think that's really interesting too, because while it's something that pediatricians and I suppose gastroenterologists more generally look for, I wouldn't say that the general population. I know that when I was diagnosed with celiac disease, I would have never thought there was any kind of component associated with the liver.
Yeah.
So I think
we
it's
might
really
mention one
to know
other
that.
thing about the liver while we have it. Hepatitis B is worth mentioning. It's this. I'm taking a little bit of a sidetrack here, if you don't mind, Kate, but I think it's worth noting that we screen all children with celiac disease to see if they have a reaction to hepatitis B surface antibody, meaning we look to see whether they've had an appropriate response to the immune therapy, that the vaccination that they get in earlier life. And surprisingly, a good many of them do not have that response, and therefore we will have them revaccinated. Not an autoimmune thing, but I thought it might be worth mentioning with the liver. Thank
Absolutely,
you.
absolutely. So treatment for autoimmune hepatitis in the cases where it is autoimmune, they would include things like immune system suppressants and things as serious as a liver transplant. Finally, your medical team would consist of course, your primary care physician, but also a hepatologist. Hepatology is not a word that's very commonly known. A hepatologist is not a doctor that's spoken about very frequently, but they do specialize in liver disorders. So a few take-home messages that I think Dr. Kersner and I would like to go over is talking about regular screening. And on an annual basis, I would say would be the typical route to go down. Autoimmune disorders can develop really at any time and become symptomatic at any time. And so testing should be done at an annual follow-up, but really only if you're symptomatic or if there are any other chemical changes in the blood that would indicate some sort of a change. It wouldn't be worth going through, taking all the blood, paying all the money to run these potentially very expensive tests. But what's also very important to remember is that having one autoimmune disease does not guarantee the development of another one. There are plenty of people who live with one autoimmune disease, and that's it. Do you have anything you wanted to add?
No, I just want to emphasize what you're saying, Kate. I find many people are fearful of autoimmune conditions, having one, and not surprisingly so. And we want to make sure that there's an appropriate balance. Yes, there is a risk. Yes, the physician caring for you should be aware of autoimmune conditions and their clinical manifestations, and be ready to look for one or refer for help if they feel lost in. But at the same time, I think it's still the minority of people who become prone to these other than type 1 diabetes. And so we should keep perspective. If there's joint pains, we're going to worry about it. If there's a skin condition, we'll worry about it. If you develop dry eyes, a dry mouth, worry about Sjögren syndrome. But at the same time, recognize that it's not an overwhelming majority of the patients who are going to go on to these in a profound way.
Yeah, exactly. And even in the small chance that you are diagnosed with one or more autoimmune diseases, it is still possible to live a full, happy, and healthy life with just a few modifications. So I think that's why it's especially important to have a mental health professional involved in your care and take care of the mind and not just the body.
Yeah.
So we want to thank you. That is the end of this presentation. Thank you so much for tuning in and learning a little bit more about the relationship between different autoimmune diseases. If you do have any questions, as always, please feel free to email us. Our email address is there at the bottom of the screen, celiac@childrensnational.org. And thank you so much once again for listening in, and we will see you next time. Have a great day.